Okay, good morning, everyone. This is the title that I picked, and I want to acknowledge that I have no disclosures, but in addition, the presentation is my own work and does not reflect in any way positions by the sponsoring organizations or OHSU, where I work in the family medicine department. I want to start with some inspirational quotes from Dr. Martin Luther King that I think, for me, related to what we're going through right now with COVID and the last 2 years since Black Lives Matter movement hit the streets. We've all come over on different boats, but we're in the same boat now. We must build dikes of courage to hold back the flood of fear. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And we'll remember not the words of our enemies, but the silence of our friends.
Dr. Krulewitch,
Yeah.
sorry to pause you. We're seeing the folder of your PowerPoints, not the actual PowerPoint. I wonder if you happen to share that window and not your screen, or if you have multiple screens. There we go. Now we see it. And then if you can just click the presentation mode.
Does that work?
Yes, that's working. Thank you.
Oh, good. Okay. So I wanted to first acknowledge that one of the reasons I ended up on this panel was that the Family Practice Department was recently awarded a grant to look at how to improve the residents' ability to do advanced directives with populations that are diverse. And the work that we did was in collaboration with Professor Seiko Izumi and Drs. Eriko Onishi and Samadhi Devarajan from the School of Nursing and the Family Practice Department. But this work is uniquely mine. And second, I just want to acknowledge everyone being here on a Saturday morning. I'm working to learn how to be an anti-racist and dedicate this work to my Black colleagues and friends, patients, families, and coworkers, and hopefully we're all working towards that. And I put the words of Dr. Kendi here, one who is expressing the ideas that racial groups are equal and none need developing, and a supporting policy that reduces racial inequity. And the objectives today, very quickly, in a small amount of time, to just use a case that highlights what are some of the disparities in care and how it affects an older Black American man, and highlights issues with structural racism, how COVID may be making that worse. And then pivot for some of the talk to look at how the 4M model might give all of us some opportunity to address these issues in our day-to-day work in geriatrics. And if there's a little bit of time to pause and look at our own well-being and ask whether or not our own ability or inability to deal with these issues when dealing with the suffering of other older adults may be causing some harm to ourselves, and what that might mean for our day-to-day work. So let's jump in right to the case. Mr. GR is a 68-year-old Black male living in a locked memory unit, and I'm going to say this is an aggregate of experiences I've had to deal with all in the last 18 months. Since his family found him unable to care for himself after he was hospitalized for acute cellulitis. He has mixed dementia vascular disease and Alzheimer's. He has frequent episodes of agitation, which we're calling behavioral and psychological symptoms of dementia, where he's angry, verbally and physically threatening the staff that try to provide him his daily cares. He does enjoy sitting in the main cafeteria with other Black residents to socialize and eat. And he's pushed staff away, but he's actually never harmed anyone since he's been in this memory unit. He recently had a cough, fever, weakness, falling, some bruising from the fall, increased confusion, and COVID positive. Let's see. He's been isolated for about 2 weeks. His behaviors have deteriorated more in the past, but he's actually improving. Excuse me. Let me go back to our slide here. There we go. He's been refusing to eat routinely, but it's gotten worse in the last 2 weeks, taking less medication. He's not allowing people to do his basic daily cares as frequently. His medications are really unchanged. His clinical status, if anything, may be beginning to improve. He has a history, however, of congestive heart failure, hypertension, cirrhosis, malnutrition, chronic kidney disease, depression, multi-drug abuse, recurrent cellulitis, the lower extremities, pneumonia, osteoarthritis. He's had multiple incarcerations. He's had frequent episodes of homelessness. His children are estranged, but his sisters are very actively involved in his care. They prefer for him to stay in the memory care unit. It's one of the nicer locations he's lived in for a long time. They know he's a challenge. He enjoys gospel music. As you are assessing him, you find out his weight's down about 5% since this episode. His vitals are stable. As I mentioned, he's actually in the 2 weeks less confused now and beginning to get stronger since the onset of the cough, which is resolving. There's no serious injuries or pressure ulcers or wounds. He can sit up, feed himself when he wants. His transfers are standby assist, but he often refuses to use his front wheel walker. He won't make eye contact with you when you see him in the room. But later, when he's at his table in the cafeteria with other residents, he smiles and greets you and chats about his morning. The administrator and social worker, both Caucasian, approach you and are asking if you could please, as the medical director, transfer him to a nearby SNF-dedicated COVID unit because he's a dangerous liability risk. They want to know why you can't consider an antipsychotic, because they think he's having some paranoid behaviors that could put other residents at risk. And they're a little discouraged that you haven't tried medication intervention. He does let one black male aide into the room routinely, but he's not allowing other people into the room at this time. So there are some hygiene issues. A nurse consultant for the memory unit then approaches you and says, he really doesn't belong in this unit. He's too much care for the staff. Some of the staff who are Hispanic are also concerned about caring for him because they're unvaccinated. You're basically approached by the senior management team again, and they're asking if you would consider as medical director moving him to another unit as quickly as possible. So what I'd like to do to unpack this situation, and we don't have annotation to work with, is to look at what are the problems that this situation is creating for you as a physician and for this patient and the staff, which would be perhaps the normal problem list you would start to work with. But in this particular workshop today, I want to unpack this with a few other questions. I don't expect us to have the time to get into all of these, but I invite you to pick a few more to brainstorm, put in the chat line, what themes from these problems would you summarize if you were to look at some of these problems? What institutions or organizations in this man's life may he have had similar experiences when he engaged those institutions? What are some of the features or characteristics common to many of the institutions that he encounters with this type of an experience? And in the end, as a human being, what's he going through if you could possibly put yourself in his shoes, which is extremely difficult because none of us can possibly imagine what it might be like to have lived this man's life. But what emotional responses would he be expected to have, or even would you have had given this situation? And I'm going to pause for a bit. And since we don't have annotation, just go ahead and put some of your responses in the chat line. And then Armin we'll have Armin call them out in just a bit.
So we have someone saying that we don't think he trusts, and it seems that it's exacerbated by race. And if anyone else would like to add on, I'll make sure to read them out loud, and we can kind of have as much of a discussion as we can have in this setting. He feels powerless about how his needs are met. So there's an issue of trust, there's an issue of power. He should stay where he is, and he can continue to interact with the people he eats with. It's kind of a middle ground option. Doubt he could trust others to help him in the past, so learned from life experience. So kind of some conditioning going on there from previous interactions with the system. Lots of observations, but any actual input from the patient. So it seems like we're missing the patient's actual words here.
Any thoughts about what other institutions in this man's journey may have provoked similar experiences for him?
Right. Someone is commenting on being incarcerated was probably a similarly disempowering to being in a MCU.
Great.
Mhm.
Absolutely. Well, I'm going to jump ahead because of time, but this is, again, a set of workshops, exercises that I learned when I worked with Paulo Freire in the Midwest Academy. And I'll acknowledge along the way some of the different people that have worked with me on these educational techniques. Here was my latest unpacking of this experience, just looking at these slides again last night. Some of the general problems, just to categorize them without putting a value judgment. There's a push to get this man out of the building. There's a request by senior management and nursing management to use medication as a restraint. There's trauma around the meal. The staff, as someone mentioned, could be triggering the experience of staff coming in, 3-4 people, to perform what they think is a routine daily care, but could be extremely intimidating and upsetting. There's medically, there's a need for rehabilitation. He's had an acute viral infection and is bedridden and staying in bed. He's deconditioned and in the process of addressing or not addressing issues of structural racism that he's dealing with. People may have overlooked the fact that he needs basic restorative rehabilitation. There's issues around the advanced care planning that there's been no recent meeting with the sisters to talk about his goals of care. There's concern around what is appropriate quarantine after 2 weeks when he's improving. What is the CDC guidelines to get him back on the unit? And there's the labeling that's going on by no one that's a psychiatrist or a geriatrician or even a trained practitioner. People are labeling him with different types of terms, which will seriously affect his care and his own well-being. And in the end, the staff that you and he are depending on have some serious concerns around vaccine hesitancy that needs to be addressed in a thoughtful, caring, and respectful manner with other staff who are primarily, in this situation, were women from Black and Hispanic backgrounds who have their own concerns around whether or not they're being treated respectfully and their concerns are being addressed. If we look at the themes, just briefly, there's marginalization, there's issues of restraint, punishment, overt bias and prejudice, clearly isolation, stereotyping, what we're calling microaggressions in terms of unintended but harmful behaviors and tones, victim blaming, and the institutions, as someone mentioned, in addition to incarceration and policing. I think it's important to understand that we don't know much about this man's life, but he may have had experiences like this, which is headed towards a life that ended up with homelessness that had to do with his own education, his housing, access to resource development, work, and then his own experiences in the healthcare delivery system with providers, with facilities, and in healthcare educational programs. And when we look at the themes of these institutions over a lifetime that he's worked with, there are some rather fundamental themes that he's been experiencing. These institutions tend to be dominant in his life. They can be perceived as immutable. They're hierarchical. There's tremendous power differential between him and the people he interacts with consistently. They're very autocratic, particularly from his point of view, but for anyone that's working there, including the primary care physicians. There's a great deal of paternalism that's going on in these institutions, marginalizing, possibly frank exploitation. Even without dementia, it may be very difficult for the individuals in these systems to understand what their rights are and what their opportunities are for advocacy, leading to victim blaming and outright abuse. And if you think about what it might be for him as a human being, if we look at all of these different emotional issues to experience this again and again in an institutional setting, there can be rage, fear, depression, dissociation, withdrawal, resistance, denial, dysfunction, even delusion, Essentially, this is a human being that's suffering. He's in a lot of distress. So I want to pivot, hold on to that case, put it on the back burner for a bit, and let's take a dive quickly into what is some of the research on disparities in long-term care and how has COVID made that worse. And I have a literature review and a final slide that goes over many of the articles I used to put this together. But just from recent publications, there's articles that have shown that Black residents in long-term care settings are more often physically restrained, receive less pain treatment for matched levels of morbidity, are more likely to have pressure ulcers, less vaccinations. A recent study I heard last week at the OGS annual conference showed that with patients with matched levels of peripheral vascular disease, Black older adults are more likely to get amputations. There's concern that the homes with increasing numbers of Black long-term residents are much more likely to get negative surveys in the health services assessment. There's more hospitalizations from the SNF and readmissions. And that while nationally, there's a very low percentage of Black residents in nursing care facilities, when you look at poorly performing homes with survey concerns that are bringing up survey issues, that the one-star homes are much more than twice as likely to have over 50% Black residents, many of whom are on Medicaid. And another study that showed that Black residents with end-stage dementia are more likely to have intubation, another study that I heard last week. When we look at the workforce in general, the workforce in long-term care nationally is primarily female, but much more diverse than what you might see in an academic setting where we train. And what's quite significant is that unlike the hospital and academic settings, which have extremely high benefit packages for their nursing staff, there's low wages, poor benefits, no union protection, minimal training, very little opportunity for any career advancement for these women. Over 80% are women. In a 2018 national study found that the median income when looking at not only nurses, but home aides, health aides, what are called the frontline healthcare workers and CNAs, the average income was $20,000, which is at poverty level. Many of these people are actually on public assistance getting food stamps while they're working, and they have no sick leave. I already mentioned that there's no advancement in the long-term care industry, but I think we need to look at the entire workforce taking care of older adults and acknowledge that in management, in our physician work pool, in our faculty work pool, there's very little representation of people of color from any other background other than the white students in medical school that are coming up the ladder. And lastly, for the workforce, because of the way the fee-for-service market has evolved in long-term care, most of the people working in the long-term care community have to go further distances to get to work from their own home setting, where they have much greater exposure to COVID and are placing the patients at risk. So let's look at what that means with COVID. Recent studies that have been published in peer-reviewed journals are now identifying that Black Americans are more than twice as likely to die from COVID, 4 to 5 times more likely to have an ICU admission, 2 to 3 times more likely than the minorities are 2 to 3 times higher than in white communities, a much higher rate of incidence of COVID. And the Black Americans were 2.7 times as likely as non-Hispanic whites to be hospitalized, even adjusting for all their factors. And another study that was done at the School of Nursing here, noticed that almost 90% of physicians who had different ethnic backgrounds found it challenging to do advanced directives. And one of the reasons it's hard to sort out some of these outcomes in disparity is that because of issues of trust and because of issues of real experience that people in the Black community have had, not getting into hospitals, not being cared for in a fair and equitable manner, there is a sense that if you don't put down full code, you're not going to get the access to care that you deserve. And so there's a much higher rate of full code in the Black and Asian community than in other populations. In a review article from the Journal of American Medical Directors that just came out 2 months ago, they broke down the literature in structural racism and disparity and looked at 3 basic issues: structural, cultural, interpersonal. And focusing on structural issues, you have the social determinants of health creating tremendous disparities in long-term care resources because of housing, education, political power, health services, incarceration, and employment in general. There is a real difference in resources developing in Black communities that are concentrated in urban areas. And in addition to institutional issues like redlining and bank lending restrictions, it's led to our healthcare system in long-term care, which is a private fee-for-service model, having private owners locating the long-term care facilities essentially in high-income communities far away from Afro-American and Black communities. And so you're looking at real discrepancies. And most of the long-term care are either going to be chain or private for-profit or private nonprofit. There's cultural issues, which I wanted to highlight also, in that Medicare does not pay for long-term care except for the first 20 days in a post-acute care setting, and then rapidly drops down to copays and deductibles. But if you look at your ICF, your RCF, assisted living, what we call the community-based long-term care setting, Medicare provides no housing whatsoever. And in the states that we're now currently seeing with voter restriction, where there were Jim Crow laws, these are the same states that have not allowed any expansion of their Medicaid programs. And so it's made it very difficult for patients at the poverty level to get Medicaid to cover a long-term care placement, reducing access to long-term care. Another major cultural issue that was alluded to from our first speaker was that by not looking at the social determinants of health, what he was calling the upstream factors, for many years, when I trained, certainly in medical school 50 years ago, issues of chronic disease were consistently identified with biological and genetic factors, and there was no mention of the social determinants of health whatsoever. And there's also a general cultural belief in the medical community that we're being more just if we don't disaggregate the data, when in fact disaggregating the data in long-term care is exactly what we need to be doing to understand what's happening and what are the outcomes based on the disparity of resources. And lastly, I just want to highlight for those of you, my colleagues attending today, that might not be frequently going to nursing homes, even in Portland, where in the state of Oregon, we have a very demanding survey team and we have very high standards compared nationally in terms of our nursing home performance, that the nursing home industry is not necessarily the meritocracy that you've experienced in medical school, at academic hospitals, or in the private hospitals you might be working at. There's a much higher sense of paternalism, nepotism, and as I pointed out, a systemic lack of retention and job development for entry-level workers. And in the interpersonal issues, I'll only point out that Dr. Kendi has pointed out that as a result of all of these things over decades and decades, there's interpersonal behavior that becomes reinforced and becomes a justification. But this behavior is not the cause of these problems. These problems are economic and political, and it's important that we learn how to improve our interpersonal skills, but we are not likely to see these institutional economic structures change just by developing our own personal skills. So this is another issue for our medical organizations to address. I am proud to say that both AMDA and the American Geriatric Society are seriously addressing both these issues over the next few years with major policy groups that are working on the epidemiology of structural racism in long-term care. But I want to pivot back to our case. If we just understand all these issues we've talked about, the bottom line is that there's a concentration of high-risk, disabled older Blacks in lower resource, lower quality homes, and COVID hits, and you basically have an increased morbidity and mortality in a perfect storm affecting Black older adults in the American long-term care community. So what can we begin to do about this? At a personal basis, which I heard people say, what can we do personally? Well, about 20 years ago, the Institute of Medicine put out this report that person-centered care provides care that's respectful and responsive to individual patient preferences, needs, and values, ensuring that patient values guide all clinical decisions. Please note that this does not say we toss out years and years of evidence-based guidelines and the use of biomarkers to identify how to best treat our patients with, double-blind gold standard interventions. What it says is that goals of care, which are the identification of our older adults' preferences and their values, can guide how we will best implement those evidence-based guidelines. But that has been so difficult to interpret and train the next generation of physicians and get into the daily care that it's kind of sat on the back burner for the last 20 years until people have begun to come up with ways to deal with it. Part of the goals of care problem, particularly as we saw with our older Black adult, is that there's no clear understanding of how social determinants of health and illness are barriers to their achievement of their own goals of care. But I did get one study that I saw from the National Health Interview from 2017 that one of our DHS staffers shared with me last week, identified that depression, hopelessness, worthlessness, a feeling that everything is an effort is at a much higher rate in the older Black American than in the white American. And I would challenge all of us to understand that these issues impact the quality of life at a much greater level than the specific medical diseases they're dealing with. So that in some sense, our own desire to be neutral and professional and focus our medical care on evidence-based guidelines may sadly be aligning our own work as doctors with efforts that completely ignore how our care can address these kinds of problems. So let's go back and see what we can do. Just in the last 3 to 4 years, we've seen this principle coming out of the Hartford, IHI, and AGS, suggesting that the 4M model might be a way that we can begin to organize our day-to-day work with our older adults that addresses their quality of life as human beings. And the 5th M is actually multimorbidity, which I tend to include because almost all my patients are over 85 and they all have 2 or more multiple chronic problems with competing evidence-based guidelines. And the general thought of the age-friendly model, which this is that if you even look at one of these issues, and certainly all 5 of them, you're going to greatly improve the care to your older adult than if you only spend all your time focusing on their biomarkers and the evidence-based guidelines and the appropriate medications that we're learning to use for the different protocols for their multiple chronic problems. So how does this work in daily life? This is the framework that I'm using for the house staff in family medicine that I've been trying to design in the last year or two. Part of this comes from work from Dr. Barbara Messenger-Rapport, who shared it with me a few years ago from the Cleveland Clinic. The middle column might be what we're normally taught to do in medical school, the diagnosis, and of course the medications. And I won't get into the polypharmacy criteria, but notice the left-hand column. Here's your 5M problems: mentation, mobility. There's medications again, what matters. And I've highlighted what matters because this now is elevating some effort, some pivot by us to put the patient's participation or the surrogate's participation and the team's participation in what we think or they think their loved ones' values are. And if the patient can communicate what they think their preferences are and put it into the same equal category as other symptoms. And I do think that as we explore their narrative and their journey, we'll see that the social determinants of health can become major barriers to achieving their goals. And I want to highlight this one statement I heard many years ago when I was training in palliative care: bodies have pain, human beings suffer. And just to highlight that the way I was taught as a physician was to treat the organic organ system disease, all of the different issues of pain, dyspnea, dysphagia, abdominal pain, physical pain. But suffering was a very difficult issue, was never raised when I was a medical student. How to assess it was considered the domain of the pastoral care team or the social worker. But if we don't come up with some way to look at human suffering, we may be aligning ourselves with medical treatments that are not addressing their own goals of care. So I do think that the age-friendly model may be moving us towards a new pedagogy of care from the SOAP model that has anchored medical training and education for 6-7 decades. Narrative really, really counts. Not only what you're listening, but how you listen, because how you listen is sending a signal. Even if you simply ask that patient or their surrogate, what does this person want for the next 1 month, 2 months, 3 months, 1 year? You're opening up your interaction to a dialogue that is empowering them, even to a small extent. It's an experience that my patients say they've never had. I get a number of residents and myself interviewing patients in the primary care clinics where we ask this one question, and sometimes people start to cry because they say, we've been going to specialty clinics for years and no one has ever asked us what we want out of our lives at this time and what it's been like to go to 5, 6, 7 clinics and get nothing but 10, 12, 15 pills. And there's never a discussion of what do we want out of our lives. To highlight this very simply, without going into a lot of detail, if someone tells you with multiple strokes, for instance, that they want to comb their hair, that may seem a mundane and not a very significant issue when you're trying to deal with all the other issues we're faced with. But in that one simple sentence, they're telling you that they care about their hygiene, their dignity, their appearance. They particularly may want to look well when they eat with their family, when they go to church, their presentation, their sense of legacy, the meaning and purpose in their life, maybe all be tied up in regaining just enough skill to use one extremity to address their hygiene. So in some sense, their gerontological goals, which we don't teach in medical school, to develop their resilience, their mastery, their interdependence, are all tied up in that simple little gesture, which if you don't ask them, what is it you want to do in the next month in your stroke rehabilitation? What is it that you're looking forward to doing when you return to your ALF? You may miss that entire interaction, so that there's a need for dialogue, communication, negotiation, and reevaluation. And where this is going to show up is in the practice that you do this day in and day out. One simple tool that I do want to offer, I call it my Dr. Krulewich's uncertainty principle. I'll take out a piece of paper in the room, flip it over on the blank side, and for the patient and their family members and surrogates, I'll draw this simple bar and triangle, and I'll point out for them, I can have many, many patients with the same health biomarkers for heart failure, COPD, chronic renal disease, dementia. But based on each individual and each family's unique values, preferences, and goals, they're going to line up all up and down this bar. And it's up to you and them to ferret out where they are going to want to go and where you think they may want to go, and share that in a dialogue and discuss it with them, pointing out that there's no one right answer, and you can't maximize, for instance, their citizenship and the risks of being completely independent with taking total control, being institutionalized, being in a situation where they may be facing multiple restraints and total coordination of their daily care plan. And between those two are a wide range of opportunities for them and you to decide where and how they ought to be living.